I will go through the basic etiquettes for the meeting. We have muted all the participants till the end of the speaker session. And for this reason, we request you not to mute your device yourself. If you have any questions, please make use of the chat feature and send the same to Himanshi Sharma. Once the presentation is done, you will be able to ask your question. I will unmute you and you will also be visible on the screen when you talk. Please note that you have the option of joining with video or without video. Please be conscious of your attire, orientation, and your display picture. Please also be aware of your surroundings. Now I would like to request Dr. Purvish Parikh to please welcome our esteemed faculty and participants and start the session. Over to you, sir.
Thank you very much. It's a pleasure to see all of you online. It's more than 105 people to be exact logged in. And without wasting much time, I'm going to request the star faculty to start the ball rolling. Our opening batsman is none other than Ankur Bal, who's going to talk about the priorities that us oncologists should have when faced with a newly diagnosed patient of ovarian cancer during this ongoing pandemic. So over to Dr. Ankur Bal, please. He is senior medical oncologist from Max Hospital in New Delhi.
Thank you, Dr. Purvish Parikh, and sincere acknowledgement to Kavina Creations and all the sponsors for making us again meet for this in this corona epidemic. And it's a difficult scenario, novel virus. So we have novel guidelines for this ovarian cancer. This is my hospital, and you can see the East Block, which is Max Devi Heart and Vascular Institute, that has been converted into a COVID hospital, and we are full-fledgedly running COVID as well as non-COVID services. So we have made our own guidelines, and we are sticking to the international as well as the national guidelines given by the ISMP-CON, the Tata Memorial, National Cancer Grid. So we are changing our guidelines daily because of this novel virus, and somehow we have a good experience of all the cancers. And we were discussing this briefly in previous webinar also. We have various cancers. So out of all the cancer, I believe that the breast cancer is the most easiest to treat among this pandemic, and the lung cancer being the most difficult one because they have the respiratory symptoms. So without wasting time, so we are concentrating on ovarian cancer since an ovarian cancer day today. So these are the oncological priorities of a newly diagnosed ovarian cancer. So these guidelines are being recently given by the ESMO. These are coming under ESMO guidelines, and believe me, these ESMO guidelines are the real guidelines because the Europe and the America are the countries which are really suffering from this disease, and they actually seeing the ground reality, which at this point of time, being very lucky, India is not facing that problem which Europe and America is suffering. So let's go on to these guidelines, which are basically from ESMO. So priorities of these guidelines had been made by a multidisciplinary tumor team decision, taking into account the patient condition, the vulnerable patient who are basically more than 65 years, pre-existing cardiovascular disease or pre-existing respiratory disease, and the available resource available in that hospital or that community, which includes the ICU setting, the surgical setting, and of course the daycare and the availability of the doctors treating this. So these all have been discussed with the oncological hub among the gynecological cancers. And during these guidelines are being made, the patient and the family was adequately informed about the risk and the benefit of these intervention. If we are moving away from the guidelines, so we are actually, the risk and benefit has been discussed in detail with the family and the patient. And these recommendations are basically depends upon the national specialty recommendation and the condition scenario in that country at that moment of time. Next slide. So the various interventions are basically the medical and the surgical. I believe radiation oncology is not that much involved in epithelial ovarian cancer. So my talk will be basically on the OPD visits, what imaging to be done, how to choose these patients as surgical patient, how to give chemotherapy, and further maintenance therapy. So regarding OPD visit, there are three priorities. So every treatment has been, every visit or every intervention has been divided into three priorities, which is high, medium, and low. So regarding OPD visit for this ovarian cancer, the high priority patients are those patients who are potentially unstable, which includes acute abdominal pain, a feature suggestive of intestinal obstruction or immediate complication, which is post-surgery. And of course, symptomatic new patients with ascites or pleural effusion or any intestinal obstruction. These are the high priority patient that should visit in OPD. The one that include medium one are the newly diagnosed asymptomatic patients with no prior history. So new patients are medium risk, they should be seen. They are not low risk. Any post-operative patients with no complication, it's a medium risk, and patient continuing on chemotherapy where telemedicine is not possible. So believe that these ESMO guidelines are highly relying on telemedicine. Even the patients on routine chemotherapy should be teleconsulted, and they should continue chemotherapy in the daycare without even a medical oncologist presence. And establish patients with new problems or symptoms from the treatment which has been given, either surgery or chemotherapy or maintenance therapy. However, telemedicine is wherever it's applicable, it should given a priority. So those patients who are at low priority for OPD visits include those patients on maintenance therapy, either bevacizumab maintenance or some PARP inhibitor. Most can be managed through telemedicine. Scheduled blood tests can be done, and the imaging can be done nearby home, and it can be visited on a telemedicine rather than physically. And for maintenance bevacizumab, the facility exists to continue supervision. So again, telemedicine and ensuring BP monitoring through various charts and urine analysis can be monitored on an OPD basis. So high priority, medium priority, low priority OPD visits. Next slide, please. So this is the priority of imaging, how to judiciously use CT scan and various radiological services for this ovarian cancer. So the high priority patients again include, similar to the surgical thing, those patients who have intestinal obstruction or abdominal perforation, either spontaneously because of the disease or because of any maintenance therapy with bevacizumab. Those patients who are at medium priority for imaging includes diagnostic imaging for clinical suspicion of ovarian cancer. This is tricky. I mean, you want to diagnose these patients and you want to put them in a medium risk. However, the low threshold for imaging includes the follow-up visit of the study when the patients are on surveillance. They are at low risk, though no need of getting CT scan. And those patients who are on PARP inhibitor or any other kind of bevacizumab maintenance, if they are doing well, the CA-125 is under control, there is no hurry in getting CT scan. Next slide. So coming on to the surgical oncology perspective, I believe Dr. Somashekhar will go in detail. So regarding surgical perspective, no mention has been given in ESMO guidelines regarding the HIPEC, either upfront or in between or on relapse. They have given the most of the emphasis was given on the cytoreductive surgery. So those patients who are at very high priority for a surgical intervention include those who present newly diagnosed ovarian cancer patient with intestinal obstruction. I believe these kinds of patients are very rare in the practice, coming upfront with an intestinal obstruction. Those patients who have a bowel perforation or peritonitis, either because of the treatment or because of the disease. Post-surgery complication like perforation or anastomotic leak are very high priority for any intervention. And clinical presentation of a pelvic mass with torsion or causing urinary or intestinal obstruction. So these are high priority for any surgical intervention. So now coming on to the medium risk, which again is very important to note, that those patients in which establishment of a cancer diagnosis when high suspicion exists, example diagnostic laparoscopy, it comes in a medium priority. The primary cytoreductive surgery itself is a medium priority, not in high, not in low, so it should be done. Possible interval debulking surgery following review by MTD, and continuation of first-line therapy with postment of surgery should be considered as an option. So I give you a practical thing which we are doing in our hospital. So instead of going for 3 cycles, then surgery, and then 3 cycles. So in this COVID era, we at our hospital are actually completing 6 cycles of chemotherapy and then taking them for surgical if they are coming in this era. And since we have seen 6 to 8 weeks of this era already, so many of our colleagues are myself also doing this practice, completing chemotherapy and then taking them for cytoreductive surgery or a HIPEC if required whenever possible. Another medium priority is symptomatic patients with inoperable primary or a recurrent cancer requiring palliative cancer procedure like a diverting colostomy or a venting peg. So these interventions also come in medium priority group. So medium priority is basically personalization. If there's a need, you should please intervene these patients. So what are those patients which comes in a low risk priority? It includes a risk reducing surgery, particularly in a patient would have a genetic predisposition to gynecological cancer, I believe Brca and other mutations. So no need of hurrying up for these patients. We can do it later when the COVID becomes silent and the curves are flattened. Benign appearing ovarian cyst or masses. So we heavily rely on clinical and radiological imaging on this. Recurrent cancer requiring palliative resection. So for palliative surgery, better to have them on a low priority. And an oligometastatic first relapse where complete resection is feasible. Again, when the burden of the disease is less, so it should be on a low priority rather than a medium or a high priority. Next slide, please. Coming on to the medical oncology perspective, which I believe should be used more often in this COVID era instead of surgery. Dr. Somashekar might have this different opinion. So high priority patients are those who require neoadjuvant chemotherapy in a symptomatic patient. I believe the symptoms are not requiring surgical intervention like intestinal obstruction or a perforation. Post-operative chemotherapy or continuation of post-operative chemotherapy for high-grade serous as well as endometrioid tumor, high-grade post-operative serous or a endometrioid tumor. And the Brca testing, the ESMO guidelines have given very much emphasis on Brca testing. If these patients are Brca positive, a germline one, so we should give priority for PARP inhibitors, particularly rucaparib. So importance of Brca testing continues as these patients are eligible for inhibitors and should be considered for shortened chemotherapy cycles. So if in a pandemic, if you are a Brca positive, so shorten the chemotherapy number and put on the Brca maintenance earlier. So this is a higher priority zone. And continuation of treatment in a context of clinical trials. So ESMO guys have given very high emphasis on clinical trials. So if a patient is going on a clinical trial, do not break the clinical trial and rather continue with all best things to offer. So the medium priority in view of medical oncology includes the first line post-operative chemotherapy in advanced stage clear cell or mucinous. So clear cell or mucinous in an advanced stage, which is 3C or 4, the first line post-operative chemotherapy is a medium risk. Chemotherapy for high-grade serous oblique endometrioid, symptomatic platinum eligible recurrent. So if a recurrent patient is platinum eligible and he is recurring after 6 months or 1 year or beyond, he should be given a medium priority for chemotherapy. So who are those patients who have a low priority for chemotherapy? So these include those patients who are recurring and they are non-eligible, means they have a poor prognosis and they are platinum non-eligible, relapsing at a very short interval. So these patients are low priority. So basically it's a triage happening through ESMO guideline. Symptomatic slow growing recurrent disease. So those patients, many of our patients are actually progressing very slowly, just ascites, no symptoms, rising CA125. So if the symptoms are slow and the disease recurrence is slow growing, we can wait for the curve to flatten down. And chemotherapy for recurrent low-grade serous tumor again comes in a low priority. So clear-cut mentioning high, medium, and low according to the patient and the atmosphere around. Next slide, please. So again, medical oncology perspective, early disease as well as advanced disease. So for early disease, which includes stage 1 and 2, what are the high priority area? So adjuvant chemotherapy, once surgery has been done, for stage 1 and 2A high grade serous and endometrioid. So it comes under higher priority. And again, continuation of a treatment in the context of a clinical trial. So if a clinical trial is going on in favor of science, continue that protocol, it comes in a higher priority. Coming on to the medium priority, so adjuvant chemotherapy for stage 1C to 2A mucinous tumor comes in a medium. And for low risk, it is chemotherapy for stage 1C and 2A, low grade serous endometrioid clear cell expansile invasion mucinous tumor. So low grade tumor, early stage 1 to 2A, low priority. 1C, low grade serous endometrioid expensive. So chemotherapy is a possible option. Again, these have been put in a low priority. So high grade tumor, a higher priority. Mucinous high grade stage 1C to 2A, medium priority, and low grade tumors are low priority for chemotherapy in this COVID era. Next slide. Coming on to chemotherapy in advanced disease, this is the most important slide of the day, I would say, for my talk. So coming on to the platinum-based therapy, the guideline clearly says that we should be liberal. So carboplatin, paclitaxel every 3 to 4 weeks rather than weekly regime to reduce visit and a risk of myelotoxicity and to decrease the exposure between patient as well as the healthcare worker. So 3 to 4 weeks rather than a weekly dose dense regime. Consider 4 to 6 cycles depending upon the response and prognostic factor, and wherever possible, reduce the number of cycles to either 4 or 5 in responding patient before adding PARP inhibitor. So if we have a BRCA positive, the guideline clearly says that reduce the number of cycle and please introduce a PARP inhibitor as a maintenance or even rucaparib as a therapeutic option. Consider early discontinuation of paclitaxel for toxicity. I believe this indication is for some of our patients have taxane-induced lung toxicity. So in God forbid, if COVID happens, taxanes can be a problem in lung. So GCSF support to prevent leukopenia, because we have seen in our practice in this COVID and non-COVID hospital where we are working. So whenever patient presents with some respiratory ailments and neutropenic and fever, we first have to rule out COVID. So prevent leukopenia, prevent febrile neutropenia by giving GCSF. The guidelines clearly say that limit dexamethasone to reduce immunosuppression. So dexamethasone, we can reduce it and use with our apricap judiciously 12 milligram or 20 milligram dexamethasone, reduce the dose of dexamethasone so that immunosuppressive properties of steroids are not there. Very important point with this ESMO guidelines that caution with bevacizumab. Why? Because bevacizumab is associated with hypertension, and this hypertension and particularly elderly age comes in a vulnerable population. So caution with bevacizumab because the associated hypertension, which may worsen COVID-19 outcome, and the use of resources with the maintenance therapy. So we know GOG 218 and the ICON study, which clearly says that bevacizumab maintenance have a OS benefit only in those patients who have ascites and those patients who have stage 4 disease. So we can debate on the use of bevacizumab. However, BRCA inhibition and use of PARP inhibitor is advocated whenever it is possible. Next slide. So maintenance with PARP, as I was saying in my previous slide, inhibitor, particularly in high-grade serous or endometrioid cancer with the BRCA mutation responding to platinum-based therapy, it is advocated, and patients who have a BRCA mutation positive and PARP naive, we should consider rucaparib monotherapy in situation where platinum cannot be used judiciously if in the presence of comorbidities and all. And non-platinum based therapy are a low priority as discussed before and should only be used after a careful review of risk benefit within your country and your surroundings. So dose adaptation, 4 weekly, 3 weekly, do not give weekly, use GCSF, avoid bevacizumab maintenance, and use PARP inhibitors wherever possible, and single agent carboplatin AUC5 every 4 weeks in a vulnerable patient if PARP inhibitors cannot be given. So these are some of the ESMO guidelines on surgery as well as chemotherapy, clearly saying that discuss with the patient, there should be a risk-benefit ratio and a judicious use of multidisciplinary tumor boards to decide on these indication. So with this, next slide. So with this, I summarize that early disease, 3 to 6 cycles, given high grade, low priority in low grade, carboplatin, 4 to 5 cycles, use PARP inhibitors, and in advanced disease, next slide. And in advanced disease, I have already discussed that dose dense should be avoided. We should give 3 to 4 weekly and rucaparib monotherapy or another PARP inhibitor if we are BRCA positive. So with these slides, I would like to thank you all my participants and senior colleagues who are there. So happy to see the next discussions and further panel discussion by Dr. Senthil Rajappa. Over to the organizers. Thank you.
Thank you very much, Ankur. This was really good to set the, whatever we need to discuss further, you have put a benchmark on that. And now we have our very senior and esteemed Dr. Soma Shekhar, who's a stalwart and a surgeon that we always look forward to hearing. So over to you, sir.
Thank you very much, sir. And good evening and welcome everybody. It's a pleasure to be with all of you. At the outset, I thank Parikh sir for helping me to really crisply define. You know, surgeons always do a big job, especially surgical oncologists, but medical oncologists nicely trim that, and I thank him at the outset. My part of the talk is more practical and then purely confined to optimizing the ovarian cancer surgery during the COVID. Can I control my slides, Kashish?
So you'll just have to, so you're controlling the slides.
Okay. See why this particular area that surgery in ovarian cancer is important. There are two most important things we need to understand. If you look at the particular slide on the right side, the COVID virus has an impact on the cancer. Cancer also has an impact on the COVID virus. Cancer patients are immunocompromised and they're more prone to have a horrible, morbid, and mortality or a horrific recovery phase during COVID. And the patient who has COVID, if he's subclinical, and then if you suddenly become COVID positive during convalescent of ovarian cancer, then they have 30 to 40% mortality chance, respiratory problem, especially we know in an advanced ovarian cancer, we have very high chance of pulmonary problem. And in advanced cytoreductive surgery in ovary, what is every surgeon, every gynec-onco worried is that of the lung problems. If you look at here, a normal person in this slide, non-metastatic, localized also, if you look at the proportion of patients who have events during recovery, and then patients who are advanced cancer. So even localized patients have a very severe event. So we need to balance both. The first rule of any medicine is, thou shall not harm the patient. So we need to be very, very important to understand this. Now my talk essentially has actually gone into three parts. That is, I have taken the ESMO guideline, and there are three very, very important articles which were published based on which my talk I have based it. So if you look at the cancer patient infected by COVID during surgery have high mortality. What is this problem? Patient looks normal, asymptomatic, incubation is 14, you operate, second week, they start developing dyspnea, pneumonitis. You don't know it is because of the surgery you have done cytoreductive or is it because of the COVID. Then we are in big soup and the mortality. That patient had a second option which could be neoadjuvant chemo and 25% mortality could have been avoided. Second thing is, even a best COVID RT-PCR test is not foolproof. 1/3 of the time there is false negative. And at any given moment, based on the stage of the ovarian cancer, risk-benefit assessment needs to be actually done, and then we need to know. Now, this is a data from India. You look carefully, why I have put this data is, even though majority are stage 3, 60% where we can do multimodality treatment, which means they could have either surgery or chemo, looking at the morbidity of the patient, comorbidity, stage, cytoreduction, optimal possible or not, we can decide which first modality of multimodality we use. But the problem comes, even in 20% we have pelvic confined disease, 10% are patients which may or may not need chemo, or it may be capsule intact, where only one modality is available, how to do. So the dilemma is advanced case, how to balance surgery, neoadjuvant surgery or adjuvant, and pelvic confined disease to do surgery, or where we would otherwise not given chemo upfront to do it or not, and remaining 10% of the time where chemo may not be required, diagnosis is not there. Remember, just because we have COVID, certain things doesn't change. Of all the prognostic factor you have, still surgery performed by good surgical gynae-onco team is only thing which gives cure. If you have not done a good surgery, it doesn't matter when, before chemo or after chemo, no amount of PARP inhibitor, bevacizumab, multi-chemo is going to cure. So identify what is the right timeline for you to do that safe surgery, which may not be right now, but when. So it's very important to understand. Now the dilemma we have in this COVID time are resource allocation. How do you use PPE? How do you use OT? Healthcare people busy managing pandemic with this, balancing the physical, mental health and right decision making. That's exactly the reason this particular talk is. So we have two demons. We know ovarian cancer is a silent killer, but also corona. How do you balance both? Don't do and have more morbidity in corona time, but don't deny a treatment, because cancer is a semi-emergency, time-bound treatment. It's not going to wait for anybody. In India, we have 1.5 million cancers every year, and the 75,000 die. We don't know whether you will die of COVID or not, but cancer delayed without any good treatment will definitely have 50% mortality. Now we know that the Indian government had given an undertaking initially in the first lockdown, don't do elective surgery. Now we look at what is elective surgery definition. ESAS guideline by American College of Surgeons is 1A, B, 2A, 2B, 3A. Now you look back, even when an ovarian cancer doesn't have obstruction, symptom, bleeding or perforation, still they fall under 3A category, which means most cancers needs treatment, some form immediately, do not postpone. This is first guideline. Second thing is, even if you look back the decision guideline that has come back, look at this low intermediate risk. Ovarian cancer which are underlined is under high, which means delay of treatment is not possible. Now, how do you maintain continuum of treatment, but yet not damage that patient? Most patients are asymptomatic. Please don't go by whether they're COVID negative or not by symptoms. Second thing is, there is a limited data that overall survival of receiving NSCT and then do surgery is not level 1 evidence. So we need to balance both. We all know proper cytoreduction, optimal cytoreduction is the only thing which makes them cure. In absence of not able to achieve optimal cytoreduction, none of them will achieve a cure. Second most important thing, if you do a big surgery in this era when there may be pneumonitis chest problem, if you delay them sending to medical oncologist, for every week delay surgery causes 4% mortality, outcome is reduced. Even though this is another study which is very important to understand, even if you achieve no residual tumor, but you send the patient late, there is compromise, which means we have two arms. Delay by a week is not acceptable. Even if you achieve optimal reduction delay, that will not compensate the overall survival. Any treatment, but not doing that surgery in that 3 week, again, there is compromise. So we have three cardinal rules to do that. So what is that we need to do different during this time? Surgery for early ovary, surgery for advanced. Now look at this case one. It is not an overview direct cancer surgery. There is a suspicious adnexal mass. On imaging, it is ORATS 5. C125 marginalized. Any imaging says no disease outside. Now should we just think it is cancer, biopsy and do NSCT or harm them with rupturing the capsule? Or should we go ahead with surgery where 70% it could be not malignant? So scenario number 2. If you have a suspicious adnexal mass where there is no proof of cancer, may or may not give chemo, diagnosis is not proved, where 10 to 15% of the time they may not be cancer, is the only scenario all guidelines say you should do immediate surgery. Kindly note, it's a low risk surgery, not very high volume, long surgery with morbidity. Now, if a patient has a pelvic confined, what otherwise looks malignancy, normally you would have operated, but remember in MDT, even now consider an NSCT because they all need adjuvant chemo. The moment you know they need adjuvant chemo, you can come back there. Please don't be too heroic. Extensive para-aortic in ovary where survival benefit is not proved, don't try to do and add morbidity. If surgery is not possible in an elderly patient, then please try to do single agent carboplatin, postpone, don't give neutropenia and look at surgery after the pandemic is under control. Now, advanced ovary cancer, the dilemma is surgery first or chemo first in an operable. Inoperable is very easy to do. I put two scenarios. Scenario 1, patient is symptomatic, ascites is there. You could otherwise operate. Should you find a heroic surgeon to operate or should you give NSCT? Remember, if you operate, you had 10% morbidity and mortality. Those patients may not go home if they turn out to be subclinical COVID or the source is not identified. The second other problem is you had a patient who started with chemo. 3-cycle NSCT is done. Ankur told me very clearly in the institution, even if you have response, they complete. Now the response is marginal, which means we know that should we now use surgery as a rescue with a maximum surgery and give complication and delay? Or should we complete all 6 chemo, finish off this and try to overcome that 6 to 8 weeks and then operate? So there's two dilemma. I will answer them in next couple of slides before I end. During CRS, do everything to remove visible disease, but avoid ultra radical surgery, para-aortic lymph node dissection, too extensive section. Remember, GOG, optimal cytoreduction definition, should be acceptable now rather than CC 0 versus 1. Withhold HIPEC. There is a very clear guideline from International HIPEC Society. HIPEC is a high aerosol surgery. Everybody in the OT is exposed for 95 minutes, especially when we know the outcome may not be very, very optimal. We don't have 100% conclusive proof of survival. So HIPEC, you avoid, do a good surgery. Secondary debulking at this moment should not be done, should all go for chemo and look at it later. In a surgical patient, avoid bevacizumab because other than platinum resistant, there is no overall survival benefit. Don't add bowel complication, which may actually alter for us. If a patient comes with obstruction in emergency, immediate surgery, try to do minimum that is required to come out of that. And all the patients who need surgery in otherwise curative option or need chemo, even though ICMR doesn't recommend, please try to test COVID, not only to safeguard the healthcare people, to make sure your patient is not going to be a subclinical COVID and then he's going to have higher mortality than normal people. So if you look at the priority, A, B, C, A life-threatening, B not threatening, but 6 weeks later you must operate, C you can wait. I will just confine myself only to one point in each slide, not all other things. Suspected ovarian, assessment should be done immediately, not necessary surgery. Suspected complication in an ovary, assessment should be done immediately, not necessary surgery. If you had an ovarian tumor, somebody has done a surgery but not staged, please don't do restaging for next 8 weeks. Don't jump into restaging unless you find a residual disease on an imaging. Rest all is medical oncology part I'm not going to touch. So this is very important. Priority B, if there is no residual disease, if just an adnexal tumor is removed, there is an indication for chemo, don't go for staging, go for particular chemo. I have last 3 slides. This is the time of ERAS. What is COVID? We don't want patient to stay more than daycare, not for long time with attendants. They have risk, attendant have risk, we have risk. So ERAS, if has to be applied now, is very good. No bowel preparation, no drains, no unnecessary tubes, no lot of pre-medication. So patient can go home by an average 30% early with less complications. So ERAS protocol should be used at this particular time, which is very important. Also, certain important thing is while intubation is happening, aerosol is happening, use intubation chamber, surgical team should be outside, come back after 5 minutes, try to use negative pressure OT. If you don't have that more than 20 cycle per circulation, minimum numbers, please use smoke evacuator. There are 3 smoke evacuators, buffalo filter, and you also have ConMed or you also have Medtronic, use one of them. Consider doing laparoscopy unless you have smoke evacuator, and then try to move all the patients to daycare for you rather than this. This is the modification we have done, which can be done, Sage is told, underwater with a filter with sodium hypochlorite. Now it is proved you can do. All the patients do infectious disease ID questionnaire, stratification, low risk, swab negative, low aerosol surgery, no HIPEC, no IP port, and high risk. Then for all of them, use PP if they're high risk or you cannot get swab or if you have high. So to summarize, suspected ovarian cancer, assessment, high level evidence. Assessment doesn't mean surgery. Early ovarian cancer, adnexal mass, please do laparotomy that gives diagnosis, may avoid chemo, and it is a limited surgery. For early ovarian cancer, don't jump for re-operation or staging. If there is no residual disease found, please wait for 8 weeks. For advanced, try to use neoadjuvant treatment more because you can still do a same good surgery after about 3 months. HIPEC, IP at this moment should be avoided for 2 reasons. High aerosol, more risk, no level 1 evidence of overall survival. So please avoid that. Try to compensate with your medical onco with any other option like weekly chemo or 3 weekly other option. Surgery reserved for new cases. Avoid bevacizumab in surgical patient when there is no level 1 evidence of overall survival and complication may be more. Recurrent cases, please don't do secondary cytoreduction even if they fulfill desktop 2 criteria. Put them in clinical trial or use chemo as an option. Thank you very much. That concludes my trial. I'll be happy to take question at the end of it during panel. Thank you.
Thank you very much, Dr. Somashekhar. I was quite concerned about the slides that you had, but you've done such a fantastic job. I'm sure that the audience really benefited from that. Now we move on to the third important topic, and we have Dr. Amit Rautan from Manipal Hospital, Bangalore, who's talking about genetic testing for personalized therapy in ovarian cancer. Over to you, sir, Dr. Amit Rautan.
Dr. Amit Rautan, I'll just unmute your mic. Just give me 1 minute. So please go ahead.
Yeah.
So you can take control by you can just take control of the screen.
Where's the arrow?
So you can just move your arrow. So you can just move the mouse. Yeah, there you go, sir.
Okay. So good evening, everyone. I thank Parik sir for giving me this opportunity being here today. Luckily, I don't have the most difficult topics of talking of COVID. I'm talking more of the conventional update on genetic testing in personalized therapy of ovarian cancer. So the understanding of the genetic testing came from the BRCA1 and 2 mutation testing and understanding about these genes. We know BRCA1 and 2 are tumor suppressor genes, and they are repairing the double-strand breaks which are happening in the DNA. And they do this via the homologous recombinant pathway. So it's very important to understand when cancers are developing, they are developing single-strand breaks, they are developing double-strand breaks, and BRCA1 and 2 are the ones which are repairing these double-strand breaks and preventing development of cancer happening. So it was seen initially that when you had BRCA1 and 2 mutations, you had a propensity to develop various cancers. And understanding the ovarian cancer, usually in the general population we talk, ovarian cancers have 1 to 2% of chances of developing ovarian cancer in the general population. But if you have a BRCA1 mutation, you have about 24 to 40% chance of developing ovarian cancer. If you have a BRCA2 mutation, you have about 11 to 18% of chances of developing ovarian cancer. So we understood that hereditary cancer goes with BRCA1 and 2 mutation, and slowly testing for this became a norm and has become a norm now for ovarian cancer management. So the question is, patients ask us, what is the value of BRCA testing? And I always try to answer these questions to my patients in 2 ways. When I'm asking them for the test, I tell them there are 2 reasons for you to test. One, I'm talking benefit to the patient, that is to you as a patient, and then benefit to the family. So for the benefit to the patient is to understand the prognosis of an ovarian cancer. Now we know ovarian cancer per se, BRCA1 and 2, has a better prognosis than non-BRCA1 and 2 ovarian cancer. So we also want to understand her risk for breast cancers, ovarian cancers, and other cancers. And then we want to offer her risk reduction strategies. So this has been the conventional thinking of why we did BRCA testing. But now we have moved to an era where therapeutic implications have come in, and the common thinking is platinum is more sensitive in BRCA1 and 2 mutations, but now PARP inhibitors have become the mainstay of treatment with these mutations. Benefits to the family, again, we have to counsel our healthy family members. We give them a genetic counseling and then test them for the BRCA mutation to understand their risk for breast, ovarian, other cancers. And then we offer them risk reduction strategies. Conventionally, though ovarian cancer is not the best of cancers for screening, we don't have too many screening modalities, but we still do transvaginal ultrasound and CA125 for mutation carriers. We know there is some role of OC pills in chemoprevention, but I think the most important factor for risk reduction strategy is the bilateral salpingo-oophorectomy, which we offer to BRCA1 and 2 carriers once they have completed their family. So the question is, when and in whom should BRCA mutation testing be done? So this is where there have been maximum changes in the last couple of years. We always believed we do BRCA1 and 2 mutation testing for patients who have a family history. We do it for patients who have younger ovarian cancers, and that's how the whole thought process used to be earlier, that ask for family history. If the family history is positive, then ask for a BRCA1 and 2 mutation testing. Or if you see a young patient, ask for it. But now all the guidelines have changed. If you see the Esco guidelines, the SGO guidelines, if you see the European guidelines, all of them say that any woman diagnosed with ovarian cancer, fallopian tube cancer, or peritoneal carcinoma, regardless of age or family history, should receive genetic counseling and should be offered genetic testing. So now we are moving to an era of testing every ovarian cancer for a BRCA1 and 2 mutation. The second question is when to test. Earlier, we used to test patients when they've had multiple relapses, trying to look for the mutation when they were looking for a therapeutic implication, because initially the PARP inhibitors were for multiple relapse patients. But soon the PARP inhibitors utility has moved up the ladder, and now we are testing more and more patients at diagnosis. At our center, we test them right at diagnosis, but it's very difficult for them to accept the testing at diagnosis. So we actually, when we start giving them the chemo, that's the time we start talking to them about BRCA testing. We start telling them to go for counseling, so that by the time they finish 1 or 2 cycles, they are prepared for the testing and they have done the test by the time we have ended the chemo. So our aim is basically we should have the BRCA report by the end of at least 3 to 4 cycles so that we are prepared for what we are planning to do next. If the patients have not been tested initially, then we should test them whenever they relapse or whenever they move through next lines of therapies. The next important question has always been, what type of test should we do? What is the best technology for doing a test? So the commonly gold standard for testing for BRCA1 and 2 has been Sanger sequencing. But we know the limitations of Sanger sequencing. It is looking at only the BRCA1 and 2, and it is looking for particular mutation. Now more and more of us have moved to next-gen sequencing. Now, with Sanger sequencing or NGS, we are picking up the single nucleotide variations. We are picking up small insertion deletions. But one should remember, in BRCA mutations, sometimes you can have large deletions and large duplications. So always, it is best to add an MLPA testing with the Sanger sequencing or with the NGS test which you are asking for. So very important, especially when you have a positive family history and you just ask for a BRCA1 and 2, it's important to understand what test you ask for. And if it came negative, please remember, ask for an MLPA. It is said that 5 to 10% of patients may be positive by an MLPA. We have heard these debates many times. Should we do a limited gene testing? Should we do a multiple gene testing? Very frankly, we as a center have moved to multiple gene testing much more. And the whole way the technology is moving forward, multiple gene testing is becoming much more prominent, though we understand limited gene testing for BRCA1 and 2 genes is also very important as a test. So another important point is to remember how to interpret the reports. There are a lot of guidelines which have looked at how to interpret the reports. We can look at all of them, but all of them are basically talking into them 3 groups. You're talking about the pathogenic groups, which are the class 4 and class 5. Class 4 is likely pathogenic and class 5 is pathogenic. You're talking of class 3s, which are the variants of unknown significances of the VUS. And then you're talking of the class 1 and 2, which are the non-pathogenic, which are benign or likely benign. So it's very important to understand VUS does not mean you're dealing with a pathogenic mutation. So if you see a VUS, we should not scare our patients, but also we should understand the lab which we are using should not really be having a very high VUS rate. So that's another important part. We should understand what tests are being done and what the VUS rates of these labs are to understand how the reports are being interpreted. Another thing important which has now moved is germline testing and somatic testing. And we hear this a lot. Do you want to do a germline test or do you want to do a somatic mutation test? Now in BRCA1 and 2 mutations, we have realized that about 14% of patients have germline mutations. These are the inherited mutations. But about 6% patients can have the acquired mutations, which are the pure somatic mutations. So it is seen that out of the mutations you're pitching up, 70% have germline and 30% have somatic mutations. So it's very important. We are increasing mutation detection rate by 30% because these are patients who will again benefit from therapy. The debate has been what sequence will you use for testing? As an institute, we are using the sequence of using germline testing first. And if it comes negative, then we are telling our patients to do a somatic testing. And then if we detect a somatic testing, we are going forward with the treatment. And if somatic is negative, we are telling our patients they are negative for it. But the other thought process is that test the tumor first. Test for somatic, test the tumor first. If they are positive, then you should do a germline to rule out whether it's somatic or hereditary. But if the tumor is positive, then you can, if they are positive, you test for germline, prove it. If they are negative in tumor testing, even these patients will have to move to a hereditary testing. So understand that if you're doing a tumor testing and if it comes negative, it is said that by technology, there may be a difference in pickups. So it does not mean that if your tumor testing is negative, don't do a hereditary testing. It still means do a germline testing. So this debate goes on. The only advantage I see of tumor testing first is you don't need to do genetic counseling for your patient because you can just send it out. And then once the NGS report comes, then you can decide if it's positive to send for hereditary with a genetic counseling. But as an institute, we do germline first. And if it's positive, then we believe we don't need another testing. So that's the advantage I feel of doing germline testing. The only problem with germline is you still need to do a genetic counseling before you send them for testing. And that's the difficulty in clinical practice because you have a lot of patients, and for germline testing, you need to really talk to them a lot to make them understand the implications to them and their family. So having a genetic counseling team is very important when you're doing germline testing. the most important advances has been the therapeutic implication in the BRCA mutation testing. And we know PARP inhibitors now have come in as a very important role to play in management. We know PARP repairs single-strand breaks. If single-strand breaks are not repaired, they become double-strand breaks. BRCA1 and 2 are repairing double-strand breaks. So if there is PARP is inhibited and there is a BRCA1 and 2 mutation, by synthetic lethality, you are leading to cell death. And that's how PARP inhibitors are working. In practice, we have seen data from all three PARP inhibitors, olaparib, rucaparib, niraparib. But in India, since the last year, we have olaparib for use. And all of us have gained experience using olaparib in ovarian cancer management. Olaparib initially was used in patients who had relapsed more than 3 lines of therapy with germline BRCA1 and 2 mutation. But slowly it said that it was so effective, why not move it up the ladder? And we saw the SOLO2 data where patients with BRCA1 and 2 mutations who had progressed were treated with chemotherapy, platinum-sensitive patients, and after chemotherapy, they were put on olaparib. And you see the PFS from 5.5 months in the placebo has gone to 19.1 months, which is very significant. It's 3 times improvement in the progression-free survival, hazards of 0.3. Having a hazard of 0.3 is really significant, and this is very, very uncommon to see this kind of hazards, but these are the hazards we are seeing with PARP inhibitors in maintenance settings and in BRCA mutation positive patients. Well, with the usage in second line setting, it clearly moved, the drug is very effective, move it to first line patients. And SOLO1 was the data which we saw from last year, where olaparib was used as a first line maintenance therapy. Patients of ovarian cancer with BRCA mutation. Now these are patients with germline also, but we saw also with somatic mutations, you kind of get the same results. So it's approved for both germline and somatic mutations. At first line, after the chemotherapy, 2 years of olaparib. And we have seen a clear improvement, again with the hazards of 0.3. More than 3 years of benefit is what we are talking about. So this to me is quite a very, not much to think about. You know, if I have a germline BRCA1 and 2 patient after first line surgery and chemotherapy, I think this is a straightforward option to put them on olaparib for 2 years as maintenance therapy. This kind of benefit has been unprecedented in ovarian cancer, and it's clearly very significant. Lastly, moving forward, now we are moving to testing beyond BRCA1 and 2. Now, and that's becoming the most talks are going into this. How can we increase the number of patients who could get a benefit from PARP inhibitors? And we've seen 20 to 25% patients have a BRCA1 and 2 mutation, but there's another 25% of patients who actually do not have a BRCA mutation, but they still come into this category, which is called HRD, or we call this, these are the patients who also could be expressed in terms of loss of heterozygosity, or LOH patients. Now by HRD, I mean they are homologous recombinant deficient patients. They have when you do the NGS testing, you're actually picking up the same kind of defects, but you do not have a BRCA1 and 2 mutation. If you're saying they're BRCA1 and 2 negative, but HRD positive. But understand, BRCA1 and 2 is a part of the HRD. So if you're doing HRD signature, it's actually looking at BRCA positive patients and also BRCA negative with a similar signature. The only problem with HRD is, as of now, HRD testing is we don't have too many tests for it. There are only 2 tests which have been approved by the FDA. There's the Myriad test and the Foundation test from the US. And also they are very confusing tests because they have a scoring system. The scoring initially used to be a cutoff 33, which moved to 42 now in the recent trials. So again, it's a difficult signature to do for our patients. But clearly there's a group of patients who would benefit. We saw the data just in the end of 2019 from niraparib in the first line setting. This was the primer trial, which actually looking at niraparib after treatment with chemotherapy in all ovarian cancer patients and looking for benefit first in the HRD population and then in the overall population. And we clearly saw PFS improved from 10 months to 21.9 months, very significant 0.43 hazards in the HRD population. And there was also benefit in the overall population, but the hazards are 0.62 here. So they broke up these patients into various subgroups and saw that. And what we saw is those patients who are HRD positive, BRCA positive, that's 30% of patients, there's a clear benefit with a hazard of 0.4, 10.9 months moving to 22 months. But if your patient was HRD positive and BRCA wild type, again, there is a significant benefit. So clearly HRD is important. Hazards of 0.5, 8 months moving to 19 months. But in patients who were HRD negative, here you see that the benefit was not very significant. It was statistically significant. We call this the HRD proficient with a hazard of 0.68, but the benefit was only by about 3 months. So again, in clinical practice, this would be a very difficult segment to put patients on to. So I think the most important role will be in the BRCA1 and 2 mutation positive patients. And then the next group will be the BRCA1 and 2 negative, but HRD positive patients. We also saw recently the other trial which looked at maintenance olaparib in combination with bevacizumab in first-line setting. This was the Paolo-1 trial. And even this looked at these subgroups. And again, it saw the same thing. If you have a BRCA mutation positive, you have a very significant benefit, hazards of 0.31. If you have a HRD positive, again, the benefit is good. The HRD positive, Brca negative, again, the benefit is significant. But here you see clearly, if they are HRD negative, there is no benefit of adding PARP and bevacizumab to your patients. So this is a group where we'll probably not be looking at adding PARP inhibitors in our patient population. So I would like to conclude, it is understanding a woman's BRCA1 and 2 status is very important. It can improve the future management decisions and outcomes of these patients. I think the next big step will be HRD testing. Only thing is we will have to have robust testing modalities, robust interpretations of these tests. We will have to understand more what HRD testing is implying, what the LOH is implying, what the report is implying for these patients. And this will be an important part in ovarian cancer management. All of us will need to understand how we are offering the risk reduction strategies. And lastly, interpretation of reports is something we'll have to learn about. Thank you very much.
Thank you very much, Amit. This was really a very insightful presentation that you made. And I'm sure that the participants now have a clearer idea of what to test, how to test, and how to interpret them. Now we go on to the next more interesting part, and that is the case-based panel discussion. And for this, we have none other than Dr. Senthil Rajappa, who always does a fantastic job of keeping everybody interested with a panel discussion. The panelists are Dr. Amita Maheshwari from Mumbai, Dr. T.P. Sahu from Bhopal, Dr. Rama Joshi from Delhi, Dr. Bowman Dabar from Mumbai, and Dr. Ghanshyam Biswas from Bhubaneswar. So over to you, Senthil, please.
Thank you very much, sir. And thank you for that kind introduction. With your permission, can I involve Amit and Somashekar also in the panel?
Absolutely, absolutely.
Thanks, great. So Kashish, can I move my slides? Is that okay with you?
So you can just move the mouse. You have the access. I've given you the access. You can just move the mouse.
You've given me the access. I am not able to get the access.
Yeah,
okay.
There you go.
Yes. Okay. So since we are running short of time, we will straight away jump into this case. So what I will do in this panel discussion is not just look at things which matter for COVID, but also try to discuss certain other important academic issues. Of course, you always have academic issues in a panel like this, not to say that. It's just to also elaborate a little bit on the practice implications of what Dr. Amit has already said. So these are the couple of things that I'll be doing during this panel. So here is a 54-year-old lady with a history of right carcinoma breast in 2015. It was PT2N1, the ER and PR were positive, for HER2 was negative. So she had adriamycin cyclophosphamide followed by docetaxel and then radiotherapy followed by aromatase inhibitor. So sometime last year she came back with back and lower abdominal pain of 2 months. Clinical examination was unremarkable. Her CA 125 was 4,200. Her CA was normal. There was no family history of cancer. And she also very interestingly had a paraneoplastic cancer-associated retinopathy. That's a very rare paraneoplastic syndrome. It's got nothing to do with this discussion as such. Since we saw something, it's worth mentioning. So you see your screen showing the PET CT scans. She had a pelvic mass with pre and para-aortic lymph nodes, some soft tissue deposits in the left iliac fossa. The uterus and the ovaries were not separately made out. So that's what our patient had. So history of right breast cancer, ER positive disease. She was 54 at diagnosis, no family history, performance status 1, just back and lower abdominal pain for 2 months, high CA 125, and that's what the PET CT scan shows, right? Dr. Amita, what would you do next? Let's assume for a moment, let's not go into the workup of this patient. Let's assume for a moment that she will have, or rather she has a second diagnosis of a primary ovarian cancer here, right? So what would
my question is, how did you get that diagnosis of
we did a biopsy.
Okay, so you did a biopsy.
Showed as high-grade serous carcinoma. Immunohistochemistry was done. The breast cancer markers were negative.
Okay, got it. So are we talking about this in COVID era or without
Okay,
COVID?
so COVID first and then non-COVID next.
So COVID, this kind of patient who has significant lymph nodes and deposits, I think this patient at our center would go for neoadjuvant chemotherapy. We have diagnosis of high-grade serous carcinoma already there. And so that's it. And in non-COVID era, I think it looks primarily a resectable disease. So I would consider her for primary debulking surgery. Just to tell why this difference between COVID and non-COVID. So the general consensus is that patient who requires extensive surgery, especially extensive retroperitoneal lymphadenectomy or bowel resection, these are not good candidates for upfront surgery in current times. Because any patient who needs prolonged ICU stay or we expect post-operative morbidities are not good candidates. Surgical morbidity and COVID-related complications are higher in these cases. So
because this patient needs a para-aortic lymph nodal dissection, bulky lymph nodes that you see on the PET CT scan and extensive surgery, that's the reason you don't want to take up this patient for surgery straight away. Is that correct?
Right.
Right. Dr. Rama Joshi, would you agree with that, or you have a difference of opinion, Dr. Amita? Or nobody has a difference of opinion with Dr. Amita? You dare not.
I think I very much agree that this seems to be a potentially resectable disease upfront. Once we are considering that we are not in COVID era. But in COVID era, better to, because what I observe here is that the nodal size, the size of the nodes are quite bulky. And this is also infiltrating so far as the psoas muscle is concerned. So when we are looking, and this is also actually occupying the entire pelvis, looks like in the POD, there is likely chance, but I would like to clinically evaluate this patient. Sometimes these patients, we do have the rectosigmoid involvement. Maybe the muscular involvement is very much there from the outside. This patient should also have the actually the rectosigmoidoscopy to exclude that there is no mucosal involvement. So there is high chance that we are likely to go with some kind of the procedures like that of the resection of the rectosigmoid if we are taking it for the considering for the surgery in order to achieve the R0 status. So I think considering all these facts that this kind of surgery may be involved during this COVID era, I think better not to do these extensive surgeries and give them the benefit of the neoadjuvant chemotherapy.
Right. But just as Dr. Amita said, you would also agree that if it was the non-COVID era, you would go ahead and do primary cytoreduction. Is that correct?
Yes, that's very sure.
Very good. So both our surgeons believe that since there's going to be extensive surgery involved, they would not want to go ahead and operate right away. Well, point taken and agreed. So we've actually spoken about the nodal dissection. I think Dr. Somashekar, Dr. Amita, both of them have clearly said that if you're going to need lots of nodes to be dissected, especially if it's stuck to the vasculature and muscles, you wouldn't want to do that. Dr. Amita, coming back to you, if you decided to do interval debulking, that's what we've decided to do in our patient, would it be laparoscopic or open?
Open. COVID or no COVID, it will be open surgery.
Okay, so Dr.
So currently, let me tell you that currently there is no good evidence to suggest that laparoscopic interval debulking surgery results same outcome as open surgery. So the standard of care is open surgery, whether it's upfront surgery or interval debulking surgery.
Dr. Somashekar, I want to bring you there in. The other day when we were in a different forum discussing, you had your thoughts on laparoscopy, whether it should be absolutely not done, or are there some precautions that you can take if you want to do laparoscopy? Can you please elaborate on that? Dr. Somashekar, are you around?
I'm
please. Laparoscopy. If you decided to do laparoscopy, is it okay to do it? Is it absolutely contraindicated, or yes? If yes, how would you do it? What precautions would you take?
Now this question has two parts. One is laparoscopic surgery acceptable in ovarian cancer?
Right.
Know that in advanced case it is not. Only two scenarios where it is. One is staging laparoscopy before evaluating, or if a patient has done an adnexectomy and it is positive and you need to do staging. So laparoscopy in COVID era is not contraindicated. The stages initially in last week of March thought to be contraindicated, but now the recommendation is to use only one cannula, and the exhaust should be done through one of the smoke evacuator, which has been already enlisted. So doing through that is not contraindicated.
So Dr. Somashekar, a significant proportion of patients, not patients, significant proportion of listeners today have probably not stepped into the OT at all. So can you just expand on what's that, pipe that's going out and the seals that you showed?
No problem. See, the issue is we all know that surgery in general across all oncology fall into two categories: high aerosol producing and low aerosol producing. Intubation process for all the patient is a high aerosol. So that is when the maximum viral load is there. So it should be done with intubation chamber. Surgical team should be outside the OT.
I agree.
Negative pressure. So second aerosol generating is, for all laparoscopy robotic, we use 3 to 4 liters of carbon dioxide to create pneumoperitoneum because we need a space. Now, none of the cannula, when we use it, we let out the abdominal gas in between during surgery. And when we retrieve the specimen, the air of the abdomen leaks out. Knowing very well that the peritoneal fluid could have COVID, this could actually aerosolize, not at the surgeon, but everybody is having a problem. So now the recommendation is from one of the pneumo cannula, the outlet is drawn through a pipe and it is put into an evacuator machine. Then like an ICD tube, you have a double underwater seal water with sodium hypochlorite. If you use this mechanism, all the gas of the abdomen goes through this filtration and sodium hypochlorite. It is found that it is not a contraindication. This is the SAGE's recommendation.
Great. Dr. Amita, you wanted to make a point. Yes. And then Dr. Rama after that.
So, So what, what Somashekar mentioned, it's general recommendations on minimal access surgery in this era. But when we talk about gynecological cancers, minimal access surgery has very limited role, especially when we are talking about ovarian cancer. I think current time I won't do laparoscopic surgery, for any patient. Cervix, it's out. Endometrium is the only cancer where you can consider minimal access surgery current times. So,
Dr. Rama Joshi, you wanted to make a point?
In ovarian cancer, actually, there is some role of the laparoscopic surgery. Especially in the risk-reducing surgery, you can go with that of the laparoscopic. The other one is when the patient already has the incomplete surgery, right, where the ovarian mass has been removed, and you go for the diagnostic laparoscopy, you have evaluated with the imaging that there is no evidence of disease anywhere else. So one can go ahead with that of surgical staging after the laparoscopic evaluation. When there is no peritoneal disease, then you can stage these patients. I think I feel that the laparoscopic has got the value in these two situations in the ovarian cancer. And I agree with Amita that in advanced ovarian cancer, as such in the interval debulking surgery and all, I don't think there is any role of the laparoscopic surgery.
Great. Okay. So all the surgeons seem to be on the same page. So laparoscopy is not contraindicated in the COVID era, but I think it's very important to understand the fact that in gynec cancers, especially in the clinical situation that we are now dealing with, it is better to avoid laparoscopy because the level of evidence for laparoscopy is not as good as what it is for open surgery. Right. So we'll now turn around and get the medical oncologist there. Dr. Sahu, Dr. Bowman, and Dr. Biswas, all the three of you are around?
Yeah.
Very good. So Sahu, when do you ask for germline Brca testing? We'll come to the rest of it a little later.
Yeah. Ideally,
tell us what you do. No, not ideally. What do you do?
Yeah. Normally, very few of my patients would agree for germline testing just because of the cost of the drug at this point of time and the consequences that it really has to go through. And third point, which I'll be very frank, is I myself do the counseling. I have to spend quite a bit of the time. I don't have a genetic counselor with me who really can assist me. So that is what I normally, around 5 to 10% of my patients go ahead and do a testing. 90% of them whom I would like to would not do a testing.
All right, great. So you'd like to do it, but most of them disagree, and your reason for not doing it.
Even I don't push them because I don't have anything to offer to them, even if they do it.
Great. We'll come back to that point a little later. Dr. Bowman, would you agree with that?
Most of my patients, I try to do the germline mutation upfront because it's just a blood test. And when they are spending so much on the drugs, I don't think so an additional cost would matter so much. But yes, counseling is done most of the time by us only. Genetic counselor is very, very difficult to get.
Dr. Biswas? Biswas?
Am I audible?
Yeah, you're audible, Biswas. Go ahead.
Yeah. So there are two things. So like this case, so definitely this makes a candidate. But not only the drug cost, because once you have a Brca positive, so likely I have a trial coming up. So I have a database for those patients. I counsel the patient the importance of that. So, okay, so if 10 patients come positive, I know that 9 of them or 8 of them may not be affording for the olaparib, but it makes sense. So all corporate patients, so definitely I do it. For all cash patients, so definitely it needs a lot of counseling and the importance of treatment, and if it is an advanced disease, so we can counsel them that we likely to have some trial coming up. So that's the reason. So I counsel them for the test.
Right. So we all seem to be carried away with this part business at this point in time. Does anybody see value in testing so that you can do prophylactic surgeries, you can counsel the family and so on and so forth? Any one of you, Sahu, we come back to you because 3 of you didn't touch that point. I thought at least one of you would tell me about it.
I exactly touched those points only. I think that it was missed with that momentum. The point is that I do not agree that just because I need a database or I can afford or
no, nothing to do with the database. I'm saying just
the point I was coming to that is when you counsel and the implications are told to the patient of the family and the daughter and the other things, very few of them would sometimes don't agree to that, even if so my point with Dr. Ghanshyam is yes, agreed that that can happen, but point is not only for database, we should be very clear the implication it has and what would the family would require to do post a positive germline mutation. That is very important.
Yeah, Dr. Bowman, is that the same experience for you, that patients decline testing after getting counseled by you or by a counselor?
Yeah, when you tell them a lot about hereditary part of it, they do get little bit turned off, saying that, oh, my child is there and they will. So those things do happen when you tell a lot of things about this. But when you tell them the therapeutic aspect of it, that there is a therapy beyond this, it is more accepted.
Right. Amit, are you around? So what is the percentage of patients who would decline testing when you tell them that there's a hereditary implication to it?
I think in practice, we kind of see those both group of patients. You know, we see those very educated patients who have read a lot.
How many percentage will say, I don't want testing after listening to your story?
So I think we test 60-70% of patients do test. It's only 30% who decline these days.
Correct. Correct. I think the point is well made. So in our hospital, in our experience also, I can't quote a number, but I would say that majority of patients agree to get tested. Maybe it's a little different depending on where you work. That's well accepted. But just for our audience to know the numbers, this is Indian data. We presented this data in ESMO Asia. Dr. Sudeep Gupta was the principal investigator of the study. We looked at 272 unselected patients with ovarian cancer across all histologies. And the incidence of pathogenic or a highly pathogenic, class 4 or 5 mutation was 21% in an unselected group of ovarian cancer patients. And the VUS rate was about 4%. If you enrich that with high-grade serous ovarian and endometrioid cancers, the incidence was almost 30%. And that's not a small percentage by any scale. So this is very, very important. Please don't think that you need a family history. In fact, in this percentage of patients who are positive, only 25% of patients actually had a family history. So family history should not be the reason, or the lack of family history should not be the reason not to test. If you want to enrich your population, it's okay to do it for patients who have high-grade serous or endometrioid. You can probably leave alone the low-grade serous, the other low-grade tumors, the clear cell and the mucinous tumors. So this is important to keep in mind. You may counsel, you may get a genetic counselor and so on and so forth, but I think these numbers are substantial enough for us to go and test after the patient agrees. The therapeutic issue is something that will come to very soon. Biswas, what method do you do if you decided to do, and is that important?
So normally only we do the germline mutation on the peripheral.
What method do you do? Where you must be sending to a commercial lab, isn't it?
Yeah, commercial lab.
Yeah, what method do they do? I mean, it's like
Sanger,
coming back to the. You send it for Sanger sequencing. All right, Dr. Bowman.
Hello.
Yeah, I can hear you. Go ahead.
Yeah. It goes for NGS generally.
Right. And Sahu?
Muted. Yeah. For me, it's the free coupon test which I normally do, and I think they have shifted to the NGS platform recently. So that is it. But yes, one thing is very important, which the last speaker spoke, that if you have a strong family history and something to indicate to, then I think we should not just stop with a negative test. And we should do higher tests with like MLPA.
Correct. I think those 2 points are very well made. So NGS seems to be the way to go because it kind of sequences much more. It picks up much more of these mutations. You need lesser DNA. You need lesser tissue to go about with. The other important thing is what Amit very clearly pointed out. There's a small percentage in some trials, a little larger in certain other series, which can range from anywhere between 5 to 15%, which are large genomic rearrangements, which can actually be missed on one of these routine testing platforms. So if you have a strong family history, and if you're very, your clinical index of suspicion is very, very high based on whatever criteria that might be, age, family history, the type of cancer, all put together, it's important to go ahead and do what is called as MLPA. I can never get these right, so I've written it down by my side. It's multiplex ligand dependent probe amplification. I'm glad I'm not going for my DM exam anymore. So that's what you're supposed to do in order to get those large genomic rearrangements, which may be missed by one of these NGS platforms. All right, so family history is not necessary. NGS is the way to go. Do MLP. In fact, many of these NGS platforms would signal you if it's missing something. So, some of these platforms have got that ability to do it so that the labs can go ahead and do it. Certain other labs do NGS and MLPA in all samples, irrespective of whether there is a family history or not. Right, we come back to Sahu. Sahu, just a little provocative here. This is about, we are getting HRD also in now. Okay, we'll look at BRC and then get on to HRD. If all comers on the 3 trials, so the PALA, the VALIA, and the niraparib study, all these studies clearly showed that for all comers into these studies, now for the audience who are not very literate about these studies, most of you are, but for some people who are not literate, these are 3 studies that looked at maintenance PARP inhibitors in the upfront setting after either CRS primary or interval debulking surgery. And all the 3 studies turned out to be positive for the intent to treat population, right? Irrespective of whether they harbored a mutation, they were HRD high, low, whatever it might be. So the question is, if all comers benefit, and this data is not only for upfront, it's also true in the platinum sensitive relapse, where you seem to be benefiting in spite of not having HRD high or LOH or the Brca testing. The question is, if you've decided to put them on a PARP inhibitor, now all of you clearly said that a significant proportion of your patients actually decline testing when you talk about the hereditary issue. So we're leaving that aside for the time being. So if you had somebody who can afford the drug, do you need to test at all? Because all comers benefit. Sahu, you can start, and then the rest of them can give me their opinions on it. We leave the hereditary story aside for the time being.
Okay, for me, if someone can afford in this era with the recommendation coming with the approval there, I will give it. Because I have a legal responsibility. I feel I'm very scared of the legal tangle. Okay. But if you look at to me for scientifically, I will definitely counsel them that it is probably not the best drug for someone who is HRD negative and BRCA negative. And the amount of quantum benefit, or as you told, across the trial in first line or second line has shown that the hazards really shrinks and the benefit really shrinks. So if I am left to me and the patient really believes me or one of my families, I'll only give it to those who are BRCA mutation or having HRD positive. Otherwise, if not left to me, I'll definitely offer it to everyone.
Sahu, that's a very confusing answer. Let's
No,
come
it's
back
not
to
a
that
confusing one.
later.
I'm very clear that tomorrow, if the patient relapses,
right?
He or she has every right to pull you down and tell if you're not offered.
Okay, so the
even
simple
if you
answer to that
don't
question
offer,
is,
yeah,
in the clinic, because of medical legal reasons,
yes,
give it
I
to
would.
everybody.
Otherwise, I'm not convinced about giving a drug to this segment who are BRCA non-mutant and the HRD negative.
Okay, okay. Biswas and Dr. Bowman, would you agree with that? There's a legal angle to this.
Absolutely, absolutely. For such,
yeah, I would first discuss with the patient's relative. The benefit is not the same. The hazard ratios are different. So we have to do a testing. I don't think so. It is a blind move that we should do by just giving it to everybody. So when the hazard ratios are different and the benefit is different, it is our duty to inform them that yes, the benefit is there, but it's very small for those patients. But still, if you wish, you go ahead.
All right. So, so Amit, what do? You must be having quite a few patients who have gone through testing and who are taking the drug. What's your thought on this point? Amit, are you around?
Dr. Amit, your mic is muted. Dr. Amit, you'll have to unmute your mic.
Okay, I did it. Okay.
Yeah, Amit, all comers benefit, don't test.
No,
because
not
there's
at
a
all.
legal
Not
angle.
at all. So I am absolutely against giving it to my HRD negative population. I will reserve the drug only for my patients who are HRD positive. See, BRCA1 and 2 is a part of HRD. So if I had a good HRD test, it would be HRD positive, I would offer the drug. HRD negative, I will not offer, because 2.8 months is hardly a benefit. We don't give bevacizumab sometimes with just 6 months of benefit. So 3 months is not a great benefit at all. So we would not offer it.
Okay, so we are divided between science and legality here. So everybody seems to be, yes, Sahu, make a point.
Yeah, about the point of testing, it has to be done, no doubt about it. And I think the only point that is at the back of it, that you have to be very honest. And if the patient then tells, sir, aapke upar chhodte hain, that's the normal answer you get. And then you are stuck really. And I feel that's the way it is reality. But you just cannot refuse it and tell the patient tells he wants it, but you tell I don't want to give it. That cannot happen. The testing is a must.
All right, so testing is a must. Very good point, very well taken, because the magnitudes of benefits that patients are likely to get with a PARP inhibitor, depending on whether you're BRCA positive, whether your HRD score is within the limits to give a PARP inhibitor, or whether you are at a point wherein the test is negative, both the BRCA and the HRD. There are some trials where there's no benefit for patients who are HRD proficient. The niraparib study is the only study which showed that even in that group of patients, there was some benefit. But as Amit rightly told us, there was a 2-month benefit in the progression-free survival, though the hazard ratio was around 0.68. So remember that as you go down from germline BRCA to a HRD proficient, the magnitude of benefit keeps dwindling down, and there may not be any benefit at all in patients who are HRD proficient. But please remember that there was no stratification based on HRD in some of these studies. There were overlapping of confidence intervals. There were situations where the trial was with very, very small numbers of patients in some select sets of patients. So very interestingly, the ASCO guideline or the NCCN nor the ESMO actually recommend HRD testing at all at this point in time because of all these reasons. That's very interesting. NCCN gives you a footnote to say that if you want to decide on the magnitude of benefit, you go ahead and do HRD testing. But if you look at their algorithms, it actually does not have HRD testing anywhere in those algorithmic stems at all. Please remember this. Don't feel bad if you're not able to test. Legally, you are still fine, Sahu, because NCCN and the ASCO don't recommend it. You can go ahead and prescribe it for all comers. But as you rightly said, and all the panelists did the same, good to test so that we understand what the magnitude of benefit is. Great. So Biswas, let's say you want to do germline testing, somatic testing. What's the sequence you want to do?
So we'll do first a germline. So if that's a negative, then probably we'll take up a somatic one.
All right, Dr. Bowman.
But it is mentioned in Esco also that if it's a mucinous carcinoma or something like that, or low grade, then one could believe on MS-MMR also as one of the ways to go ahead and then find it out. That means the somatic testing, especially for mucinous.
Okay, so you're saying somatic is for mucinous, you would want to do Sahu?
Yeah, and MS-MMR also.
Hello. Yeah, I think nothing more to add. I think it is well that either way, if you go, you have to do, if the germline is positive, that stops there. But if there's a somatic, then you have to anyway do the germline. That is well alluded to.
Right. So Amit, can you just expand on that? Because just to make a point, all these studies that we are talking about, the Papola, the Valia, and all these studies actually didn't start with germline mutation. They didn't start with germline mutation. All of them did the testing on the tissue for HRD and the the BRCA mutations, and we really don't know if all of them went back to look at the germline. I'm sure they did, but that's not part of the manuscript. So since the world is moving in that direction, wherein we do somatic testing, and then depending on what the mutation is that you find on the somatic testing, you may want to go back and do the germline testing. So Amit, can you expand on that, and what are your views on this particular issue?
So I am not,
if given a choice, would you do somatic first and then go retrograde, or you would stick to your algorithm that you spoke of?
No, I still would stick to my algorithm. The reason is very simple, that you would end up with just one test in many patients, because your germline testing, if it's positive, you can stop there. But if I am talking of somatic first, then I will end up with testing both for all patients. So being positive or negative, I will still have to do the germline testing. So I prefer a germline testing first. But yes, this is in the era when we still don't have HRD signatures in India, or I would say we don't have validated HRD signatures in India. So this is fair enough at present. Once we get very validated HRD signatures, then the somatic testing pickup rate will become much more, I feel.
All right, great. So yeah, Sahu, please make your point.
Even if you do the somatic testing and it's positive, it's good for the patient. You're done for the patient. But at the end of the day, you have a responsibility to also do a germline testing, because you have the obligation to tell that if there's familial risk or not. So if you do a somatic, you are going to do 2 tests. But if a germline positive, I agree to that. And if it's negative, then you can go for that extra testing. I feel that sequence would be more okay.
Okay, so at this point in time, the practicality seems to dictate germline testing first and somatic testing, but the way the world is going, and that's where we will end up very soon. If the bioinformatics panel clearly tells us what's germline and what is somatic, I think that's where the problem is, because the bioinformatics panel is not good enough for us to learn just from somatic testing as what can be germline and not. And that's the reason why all our panelists are saying that you might end up needing to do 2 tests. And so from our standpoint, the practicality is to do germline and then go ahead and test somatic if it's necessary. But that's not the way the world is going. We discussed about HRD. HRD gives you what's referred to as a genetic instability score. So this is what it gives you. As Amit rightly pointed out, the reason why we are not using it routinely is because of availability, and also across trials, the cutoff that you say to denote somebody as HRD deficient or not is different, 33, 42, and so on and so forth. You could go ahead and test at random genes, something like what you do in prostate cancer. Now, there's data in prostate cancer that if you test for some of these genes and you use PARP inhibitors, there might be benefits, but the benefits still are better for the germline mutations. Biswas, all the PARP inhibitors are in front of you, and so is your patient with a germline Brca. What would you pick? Or they all the same? Cost is not an issue. First line treatment.
But only my experience has been with olaparib only. And definitely for the other PARP inhibitors, the availability is also a problem.
So if in case it's available, would your choice be different? You would, let's say, ditch olaparib and then go and do niraparib or veliparib?
No,
you wouldn't. Dr. Bowman?
And I don't think so. There is a great data for PARP limiters.
Okay, so you're not.
Toxicity may be a little bit, yeah, but I don't think so.
Sahu, go ahead. No, your
All
mic.
are available, and the hazards is really same for every of the part. I will go for the cheapest one.
You will
all
go for
said and
the
done. But one thing about niraparib which I wanted to really point out, it's one of those who are not metabolized to the cytochromes. And
Okay.
if there is multiple drugs the patient is taking on multi-drug therapy for hypertension, other things, I'll be very comfortable with niraparib.
All right.
And that is
Amit,
one thing which I felt was very important.
Very good. Amit, what are your thoughts on olaparib plus bevacizumab? Blockbuster.
A very difficult. So
that's why I'm asking you that question.
so for us, theoretically, it sounds really good to me. So we've always liked Bev. Actually, whatever said and done, we were quite big proponents of using Bev in ovarian cancer, and we have been doing that. So you always keep thinking if you added olaparib, you probably will get better results. My reluctance to do so is this trial did not have an arm where it was olaparib alone.
Absolutely.
And that's what Paolo makes me very uncomfortable. Absolutely. Is that benefit you're getting? Would you have got it if you had olaparib alone? So that's the reason why we would be very reluctant to pick that up. You know, if they are germline Brca, then it would be PAP, olaparib alone. If they are HRD, then niraparib or olaparib, depending on niraparib has the data. I don't know whether we do the combination straightforward.
Sahu?
And I have one point to make here. I understand the concern, and it's very valid concern. The only thing is now there was no data for something to add on to bevacizumab, because if you are already on a, let's say, a suboptimal reduce, you have done the ICON 7 protocol, and you had that the bevacizumab to go on for approximately 15 months. So now what is happening is you have a data with you to add a PARP to a bev. So that gives you that little bit of liberty to add olaparib to a bev, which before this trial, you did not know what to do with this. And definitely the concern of olaparib single agent is noted.
Yeah. So I think the point is that if you look at germline Brca mutant or somatic Brca mutant, and you cross compare the solo and the pola, the hazard ratio is almost the same. So I think there's no value of adding bevacizumab to that group of patients. It's clear that olaparib really does not benefit patients who are HR proficient. And I think that's again from some subset analysis. I think in this middle group, which is HRD that is low, the HRD that's positive, whatever you want to call that as, whether there is some role in that group, I think personally there's no role in that group also. So for me, this combination is really not something that I would use in clinical practice, even if everything was available in front of me, because of the way the trials have been done and the way the data has actually panned out. Sahu, one question to you. Yeah. Where would you use bevacizumab?
Bevacizumab for me, I normally reserve it for suboptimally reduced stage 3. Or
would you do the Brca testing before deciding on bevacizumab, or it doesn't matter?
No,
it doesn't matter.
I don't do it. I don't do it.
So suppose I say that based on again subset analysis, GOG 218 and the upfront GOG studies, there's absolutely no benefit of using bevacizumab if you had a germline or a somatic Brca mutant. Would that can I sell that point to you, or you won't buy it?
No, I would not at this point.
You're not going to buy it. Great, no. Dr. Bowman. Who gets bevacizumab in your practice today?
Yeah, as most of them, in fact, I use it in a platinum-resistant relapse. That's the place where I use the most bevacizumab, or in a platinum-sensitive relapse, other one. Upfront, of course, there is data, but not so much what Sahu said. Is not so much in use in it.
Yes, Sahu, quick point.
ICON 7, look at it. All patients, no benefit. If you look at the high risk, which is the suboptimal stage 3 and stage 4, there is a sharp difference in the curve. That just cannot be just let go.
All right, Biswas, you agree with all of them? Biswas?
Yeah. So yeah, upfront and recurrent setting. So as you say, holy water. So for
holy water, great, nice way of describing. Or is bevacizumab the drug in search of a disease, right? Whichever way you want to call that as. Okay, so just to summarize that part, who would you do bevacizumab? I think a scientific answer to that question. Okay, we have our problems, our patients, and the financial issues, and so on and so forth. But in an ideal world, I think that would be a patient who is HRD negative and a Brca that's negative. So that's probably a group wherein it would be really worthwhile using BEV. In fact, there is some data that the hazard ratio might actually be much better than what you got in the ICON and the GOG studies. But considering the fact now that even if you got a mutant patient, you would not be able to use a PARP inhibitor in the majority of them for cost reasons. I would personally not use BEV in that group of patients if I found out that there is a germline BRCA mutant. But this is based on subset analysis. But at least some of our panelists seem to believe that if that patient still is a high-risk patient, which means a suboptimally debulked stage 3 or a stage 4, they would be okay to use bevacizumab in that set of patients. I think that's reasonable in this situation at least. Okay, so the bottom line is test. Okay, so that's the most important thing, because unless you test, you can't get into this algorithmic approach of what to do and what not, and so on and so forth. So some quick questions before we get on to a rapid fire and then wind up. Biswas, weekly versus 3 weekly COVID era?
So COVID, non-COVID, so weekly has only a very small place. We know that very frail patient, low albumin patients, and extensive disease, where your patient may not tolerate well. Right. Otherwise, the standard 3 weekly chemotherapy.
Right. Amit, you said you're a fan of bevacizumab. There's some, thing on bevacizumab induced hypertension and COVID. So, is that really a concern?
So I don't know, so this is what, once our COVID cases will increase, then we'll start understanding this much better.
Karnataka seems to be doing very well, Amit.
Yeah, that's the reason I think, and I hope to stick on that and we continue this way. I've not changed too much in practice in treating as of now.
Absolutely. So have I. So because the, Madhya Pradesh is, really bad. So Sahu must be having greater experience of, having encounters with patients who have potential COVIDs or COVIDs themselves. Sahu, how frequently have you needed to use GCSF with Paclitaxel? I think that's again something that the ESMO says, GCSF with Paclitaxel. I can count the number of patients that I have used in 20 years.
Yeah, I think some 20% odd patients have required it. Nothing great beyond that. And elderly, I started using it so that they don't have the neutropenic episode.
All right. Dr. Bowman is out. Biswas, what about steroids? Have you modified your steroid use in these patients?
Normally, we give 16 milligram of steroid dexamethasone only. I don't think that makes a big impact. Not like many of our senior colleagues who use 24, 32 milligram. So 16
so Biswas, you're pointing at your senior colleagues. That's all right. So I have cut down first cycle 16 if all is well. In fact, I even cut down to 8, whether it's COVID or no COVID. And similarly, in my weekly regimen, I start with 8 and go down to 4 if the first couple of weeks are uneventful. So I think we have always been, overusing steroids when it's actually not as much necessary as what the trials say. Are the surgeons there? Dr. Amita, Dr. Joshi?
Sir, Dr. Amita is there.
Amita madam is there. Somashekar sir, are you around?
Yeah, I am there. I'm muted.
Okay, great. So next, we are done in 3 minutes. I'm just going to do a rapid fire now. So all of you wake up in case you've been sleeping. I've been keeping the medical oncologist busy. So surgeons up. So yes, no answer. Dr. Amita, restaging for inadequately staged early disease. COVID era, for all, for none, for some.
So COVID era, none.
None.
Right. Otherwise, some.
Otherwise, some.
No dissection for clinical N0 early stage. Dr. Amita, yes, no.
So COVID era one can, but otherwise, yes.
Otherwise, yes. Dr. Somashekar, fertility sparing surgery.
Answer to the first question is
no. That's not the question for you.
No. The answer. The evidence is already there. I gave a recommendation for first.
That's okay.
So he agrees with me what I said. Right?
Second one, where there is no evidence of chemo, yes, no dissection in early, not in advanced.
Very good, excellent.
Frozen section for stage, what is FSS?
No, that's not frozen section. Fertility sparing surgery for 1C ovarian cancer, yes or no?
Fertility surgery would not change in COVID era. The guidelines would be same.
So do you do it?
No, it is. Are you talking about fertility sparing?
Not going to change. So as a rule, 1C is not, but I need to really look at patient to patient.
Great. Amita, madam. 1C.
So it's not absolutely yes, no. You have to have some option there in fertility sparing surgery for stage 1C patient. There are select patients who we might consider fertility sparing despite having stage 1C disease.
Great. The question back to you, Dr. Amita. Is there a proven benefit of overall survival benefit with adjuvant chemo after adequate staging? Are you convinced that there is a benefit?
So the answer is no. Is
Great.
if we
We
take
leave it
action.
there.
Okay.
We leave it there. So she is not convinced that after good surgery, there's any role for any of you guys sitting there. Sahu, Biswas, Amit, and so on and so forth. Okay, Sahu, to you. Lack of randomized controlled trials with Paclitaxel in stage 1 and 2 ovarian cancer, is that a concern or you've never looked into it? It doesn't bother you? There's absolutely not a single randomized trial.
Yeah, that's a concern, but I think the...
You've moved on.
Yeah.
Okay, great. So that's a concern, but we moved on. Great.
Yeah.
Okay. So carboplatin single agent versus Paclitaxel. Biswas, are there any instances these days you use carboplatin single agent, adjuvant setting?
So not adjuvant. So there was
adjuvant. This is a rapid fire on adjuvant.
Adjuvant, very frail patients, so probably won't tolerate. So to give some form of chemotherapy, so it's okay.
Again, so that's a very interesting answer because there's absolutely no benefit. There's no clear proven benefit that Paclitaxel is better than single agent carboplatin in this particular setting. Excellent. Sahu, 3 cycles or 6 cycles of Paclitaxel?
Except for very early stage, I'd still go for 6 cycles.
You'll go for 6 cycles. Very good.
Standard, except for very specific.
Okay, Amit, 3 cycles for some, 3 cycles for none.
3 cycles only for the very early stage, otherwise none.
What is this very early stage? Then don't give chemotherapy.
1B.
Oh.
I think it is non-serious.
Okay. We move on.
Yeah. 1B.
1B, either way, don't need chemo.
Correct. So we'll come back to that. I'm glad this is interesting. Sahu, Paclitaxel or Capox for mucinous carcinoma?
Not sure, but I think...
Not sure. Great. Doesn't matter. All patients with clear cell need chemotherapy.
Yes.
Okay.
Except
Great.
1B.
Okay. In the COVID era, 3 or 4 weekly chemo, Biswas?
So 3 or 4, so it doesn't make much difference. If patient can come to my hospital, so I'll give you
3 weekly. Okay, great. I think the point is that we need a great panel to be done on adjuvant therapy of ovarian cancer, which might be as interesting or even more because there seems to be more ambiguity there. Last word from the lady and then we move on. Dr. Amita.
No, I just want to ask the question. If you don't give chemo now for some of these borderline kind of cases, clear cell carcinoma where benefit is not proven, in, especially in COVID time. So are you going to give when COVID is over? A patient of clear cell carcinoma, you don't give chemotherapy because of COVID concern and, so after 3 months, 4 months, would you give chemotherapy?
No, I don't think we would do. That's a little too late to get any benefit at all. Personally, I don't believe there's any benefit in clear cell, but that's for a different day. We'll debate it a different day. So we wouldn't do that. Thank you so much, all panelists. That was great. I think we did a reasonably good job in the half an hour, 45 minutes that we've been boring all the public. So I will hand it over to Dr. Purvish to continue the discussion, taking questions from the audience. Thank you all so much. Thank you, Dr. Amita. Thank you, Amit.
And thank you, Senthil. As always, a very wonderful panel discussion, interesting.
Thank you. Thank you so much. Thank you so much, Dr. Amita. Back to you, sir.
Is he there?
Paik, sir, I'll just unmute your mic.
Can you hear me now?
Yeah.
So I thank all the panelists, plus please, and the faculty, please don't go away. There are a lot of questions. The first question that was asked was by R. Prasanna. Can you unmute R. Prasanna so that she can ask the question?
Please go ahead, sir. Ma'am, sorry. Dr. R. Prasanna. Yeah. Please ask your question. So I'll just read the question. The question was, is COVID testing must before taking patient for chemotherapy?
Senthil, can you answer that question, please?
You want me to answer that question? No, at this point in time, we are not doing. In an ideal world, yes, but for various reasons, practicality is most important. We are not doing COVID tests for all our chemotherapy patients.
There are certain institutions and hospitals that have said that COVID testing is mandatory before starting chemotherapy. And those institutions, of course, they are doing it. But as you said, practical issues are that it may not be possible to do that. Thanks very much. The next, can we unmute Vedant Kabra? He had a question that he wanted to ask.
Please go ahead, sir. I have unmuted him.
Yeah, so there is a 44-year-old lady, and I think a similar case actually was discussed on panel, but still with a 10 centimeter ovarian mass, which is causing mild to moderate hydroureteronephrosis, likely to be extrinsic pressure, with FDG avid pelvic and para-aortic nodes, but no ascites. And there is no obvious peritoneal disease also. So would you recommend upfront surgery, or in COVID times we go for biopsy, NSCT, and then surgery?
Can we ask Amita to answer that question, please?
Yeah,
Amita.
hi Vedant. I think we discussed this. If you think surgical procedure is going to be a little bit morbid in terms of extensive lymphadenectomy and patient with huge mass, especially if it is adherent to rectal sigmoid, there is a possibility of bowel resection. In current times, I think I would do a biopsy and send up for neoadjuvant chemotherapy.
Bowel resection is unlikely to be required, but para-aortic nodes are there. So nodal,
right.
Yes.
Yeah. So I
think other part is there is no ascites and there is no evidence of peritoneal disease as such on PET scan, but it may still be there.
So had it been non-COVID times, definitely surgery.
Yes.
But now with this current time, I think biopsy and chemotherapy. Unless, of course, it is some histology which is not sensitive to chemotherapy, then I think we again need to discuss with the patient.
That will come to know only after biopsy. Okay.
Right. The other thing, I think what we are discussing, India currently, if you see, it's a very, very heterogeneous kind of situation in the country. So what I am talking about essentially based what we are seeing in Mumbai and at Tata Memorial Hospital. But if you are at a place where there are not so many cases of COVID, something like Manipur, Mizoram, your guidelines don't change. You continue what you were doing before COVID.
Okay. So I am in Delhi and we do have a good number of cases.
Right. So Delhi, Mumbai, I think Pune.
And so far, our hospital was not designated COVID, but from Monday it is going to be. So
Tata, we actually are taking all cancer patients with COVID. So we have a fair number of patients and staff positive, and we are a bit careful.
Okay. So so far, no COVID positive patient as yet who has been operated.
In fact, our total positive has reached 3 digits. So.
Oh, okay.
Yeah.
Thank you so much.
Can we unmute Raja Thirumalai Raj? And I think all the surgeons, Amita, Somashekar, and Rama, can answer the question that she is going to be asked.
Hi.
Hi.
Please go ahead with the question.
Hear me? Thank you. That question was, I directed the question to Dr. Somashekar, but I suppose that can be for all surgeons. Today I had the opportunity to be in, let's say, another webinar in which I would hear a diametrically opposite view as to whether we should really change our practice according to the COVID or not. And again, as Dr. Amita just pointed out, it's going to boil down to which place, which city you are, and so on and so forth. Then again, a very, very eminent faculty from Mumbai would say that that there is no merit in changing. So leave the individual comment, but my question to the surgeons is that we all base our recommendation based on what we learn from Western data, be it NHS, NICE or Esco. Is there any early Indian data on the outcome on post-surgery patients who had been inadvertently COVID positive or in subset? Is there a learning out of these so that we'll be realistic in what we recommend to these?
Right. So, Mayu?
Yeah, I can take this question. Ours is one of the hospital where elective surgeries have not stopped. Since the first lockdown 2 phase, now we have done about 23 ovarian cancer surgeries. Every day we do cytoreductive surgery. And then of all of them, only one patient actually had a doubtful COVID. So we don't have any change in the morbidity, mortality, recovery, outcome change in this limited over 23 patients. And we, in our hospital, we do all the only thing we have stopped is HIPEC because of 2 reasons. Definitely high vaporizing surgery, and it is not a level 1 evidence of overall survival benefit, and definitely 4% morbidity is more. So otherwise, all other surgeries we are doing, but we follow a protocol of swab testing, HRCT lung, in all the patients, and then with the precaution, universal precaution, we operate. And none of the patient had a different outcome than anything. I happen to also interact with my colleague Gynae Onco from Lyon University from France. And they also surprisingly don't have a different surgical outcome in terms of morbidity, mortality in a patient who are COVID positive also. But however, these are not randomized trial. We didn't find the same thing like what was there in Wuhan. Having said that, every setup is different. We need to go with caution.
Right. So just to add, we recently looked at our cases. We operated from 23rd of March till 30th of April, and this has gone for publications. So all cases put together, all surgeries, around 596 selective cases, including all surgeries. And we have 6 patients who were diagnosed positive post-operatively. These were cases when we were not doing a testing for all patients, which we have started now for all pre-ops. And so far, none of them actually had any adverse outcome. So there is no mortality and there is no increased morbidity. 6 patients were diagnosed positive post-op.
So I think we require to have the Indian data collected and basically we'll come to know that what are likely the post-operative outcome of these patients. And so far as the small numbers are concerned in the various institutions, most of the, I think, the experience goes with that there had not been much of the morbidity in this COVID era. We have also done almost 25 surgeries during this COVID era, and we have also not had any kind of the complications still.
Just to add, Dr. Raja, we have, Tata Hospital has issued guidelines which are available. Maybe I'll share with you later. So detailed guidelines are available.
Thank you all surgeons. That was really enlightening. And if Parvish permits me one quick question,
you had one question for Senthil and Ankur.
The panelists have very well answered the maintenance, so I'm not going there, but I have another question.
Okay.
Based on what all of them answered on Brca testing and not. See, let me narrate a quick real-time experience. A patient who comes and standard treatment relapses. And then I do a Brca testing, turns out to be Brca positive on relapse. And of course, a very amicable patient then would turn around and ask me, if you had done the Brca testing at diagnosis, I would have had the opportunity to have this on my maintenance. So that was a real-time experience. There is another young, well-informed patient who would take it even further, and we do both germline, somatic, Brca, and all negative. Then would explore the possibility of sending it to Foundation 1 and thereafter to Myriad. And Myriad would come back with a test that says that Myriad genomic instability test positive. So now HRD scores have already come into the play, and do any of the panelists really take it forward when Brca 1 and 2 is negative, when you have a young patient, when these scores become positive or instability tests are reported to be positive, would you act on that? Would you use
Can I ask Senthil to answer first, and then we can unmute Ankur for his answer? Senthil first, please.
Thank you. I'll be thankful.
Right. Okay, so if the HRD score is positive and understanding what that positive score is, assuming that it is more than 42 or equal to that, then certainly that patient would be a candidate for a PARP inhibitor. Now the question is, if you are not doing the HRD score and your somatic and germline panel has come negative, then what is it that you do in that kind of a situation? I think if you look at the NCCN guideline, it gives you the option of, if you have already started with bevacizumab, for whatever reason, if you believe that that's a drug that's to be used in this particular setting, then irrespective of the HRD, as I said during the discussion, NCCN does not really recommend upfront testing for HRD itself. The NCCN says you can use a combination of olaparib and bevacizumab in this condition, because in the intent to treat population, there was improvement in the progression-free survival. If you can lay your hands on niraparib, then that would be even better, because even in the HR proficient population, though the absolute benefit was 2 months, you can still use niraparib in that particular situation. So the simple answer to the question is, if your patient understands that the magnitude of benefit can be less, it's not wrong to use a PARP inhibitor plus minus bevacizumab in that kind of a setting.
Double is okay, Senthil, but there is the data on bevacizumab upfront maintenance clearly showed detriment in BRCA positive patient. That is the only subset where it was negative. So shouldn't we be really looking at that to decide on patients?
So in HRD, in the HRD population, it's not detrimental. So there is, so the first thing is it clearly showing that there is detrimental? I don't think there is any trial to say that if you had bevacizumab to that BRCA positive population, there is detriment, because all of these are retrospective unplanned subset analysis, which are not powered for any of these things that we are discussing about. All of them were stratified only for the BRCA positivity or not. They were not stratified for HRD at all. And that's why none of the guidelines actually ask you to test for HRD itself at this point.
Detriment. I'll probably dig it out and send it out.
Yes, sure. I don't think there's data to say that it's detrimental. There is data to say that it doesn't benefit.
Okay, can we ask Ankur to give his inputs on the same question?
Sir, Dr. Ankur has left the meeting.
Okay. Then can we ask Dr. Sahu to answer? Is Dr. Sahu there?
Yeah, so we'll just unmute him.
Yeah.
Dr. Sahu, please go ahead.
Yeah, I totally go with Sendil. I don't think most of the subset analysis what sir is speaking to definitely is not powered to answer the question. So in a patient who's very pushy, I would not hesitate to give it off. But luckily in my practice, I don't have such type of patients. It's a very clear answer.
Excellent. Can we unmute Anjana Chauhan, please? She wanted to ask a question.
Ma'am, you'll have to unmute yourself.
Anjana, can you unmute your mic, please?
Hello.
Yeah, go ahead.
Sir, just I want to ask regarding the genetic testing. If the somatic genetic testing is negative, then do we need to go for germline testing?
Bowman, if you are there, can you answer that question, please?
Yeah. The first thing that we always do is, most of the time, it's a germline mutation. That's the first test we do generally. Only if germline mutation is negative, then we go ahead with the somatic. Because if germline mutation, as we discussed, so that's the first thing we do. Then we don't have to do a somatic mutation. But if we do a somatic mutation first, then maybe you have to do a germline also. And somatic mutations are the ones which are generally done for, as I told you earlier, for mucinous or low grade, where we expect, these are the patients where we do a somatic mutations, mucinous or low grade. If at all germline is negative, in such patients, you may do even a somatic then.
Okay.
Excellent. Thank you very much. Okay. Can we unmute Anup Toshniwal, please?
Dr. Anup, your mic has been muted. Please go ahead, sir.
Sir, which is the lab currently where we can do comprehensive breast and ovarian panel, including MLPA and HRD status? Is any lab where HRD status has been done?
Senthil, can you answer that, please?
Not being done anywhere. At least the Myriad test is not being done anywhere. You have to get in touch with them. You can see Myriad being mentioned in the Positive Biosciences website, but I don't know. I have never done it through them, so I will not be qualified to answer that question. But as much as I know, it's not, because we've had some ad boards where people who routinely do these tests come on. And in fact, Amit also in his talk said that. Now, in terms of doing the germline and somatic BRCA, again, somatic BRCA, if you really want to do, I think the best thing is to send it to Foundation, because that's the best test that's available at this point in time. They will also be able to give you a loss of heterozygosity, which is part of HRD, not really a substitute for HRD itself. Germline is something that many commercial labs are doing, and most commercial labs that do the standard, so-called standard within inverted commas, whatever you call that, also do an MLPA along with the NGS that they do. So I think any standard commercial lab should be able to do the germline testing. Somatic is a little more difficult, HRD not being done.
Thank you very much. Can Bhagya Lakshmi be unmuted, please? And sorry, Dr. Bowman wanted to add something. So can we have Bowman?
I just wanted to say what we are saying is HRD and somatic, they are just forms of Brca-ness. So whenever we have any mutation, germline mutation, or we do not have a germline mutation, we have to document a form of Brca-ness. And these are the things by which we could document. And I had one patient who was BRCA negative and had sent to Milan, and where we got HRD, and that patient we have started him on olaparib maintenance.
Excellent. Can we unmute Bhagya Lakshmi, please?
Ma'am, your mic has been unmuted. Please go ahead with your question. So I'll just
Bhagya
read
Lakshmi?
Dr. Bhagya
Yeah.
Lakshmi's question. No olaparib if no BRCA testing or BRCA negative. That's the question.
Yes.
Sao, can you take that? Or Senthil, you are there.
Yeah, agreed.
Please go ahead.
Agreed. Answered.
Excellent. Excellent. Fantastic. There was one more question from Rohit Kumar. Can we unmute Rohit Kumar, please?
So please go ahead with your question.
So just wanted to know your opinion regarding dose strengths versus standard 3-weekly chemo.
Ghanshyam, can you answer that question, please?
Ghanshyam sir is on the phone, sir.
Okay, then Sauk is there?
Yes,
Yeah.
sir.
Please go ahead.
For the Japanese trial actually brought in the weekly dose dense into very good because they showed a survival benefit. But when the GOG came and then it was shown that really you do not have a benefit of a weekly over a 3-weekly. So now the world has again shifted back to 3-weekly. And I think the weekly is only reserved for those whom you feel is that they cannot tolerate a 3-weekly, old, frail patients. Otherwise, now the standard of care, except for probably in the Far East, would be a 3-weekly.
Excellent. Thank you very much. Can we unmute Samir? You wanted to ask the question. Samir, please.
Dr. Samir, you can ask your question. So I'll just read Dr. Samir's question. 71-year-old lady with stage 3 cancer, ovary, not for upfront cytoreduction. Sorry, there is case
Known case of CKD, creatinine 2.5. What is the best chemotherapy regimen for such a patient? Senthil, will start with you and then take Bowman and Sahu and Ghanshyam.
71-year-old frail lady, first of all, weekly rather than 3-weekly, that's one. So weekly paclitaxel will certainly be there. 2.5 is not a contraindication for using carboplatin. You have to do your AUC and dose it based on the AUC. So it's fine to go ahead with AUC 2 plus 65 or 80 per meter square, depending on what the frailty of that particular lady is.
Right. Bowman, do you agree or you would do something else?
I think so. Weekly paclitaxel with carboplatin AUC of 2 or 1.5 also should be good enough for a 71-year-old lady with most likely by G-CSF support also.
Excellent. Sahu, are you ready to answer? What do you think?
I agree to most of it, but we have found 71s who are very fit enough. So I would not hesitate even to go for a 3-weekly. And the AUC is the way, a 5 to 6 AUC will be the point of calculation.
So if the GFR is 12, Samir has just put that on the chat, then what would we do?
Same, you calculate the GFR is 12 and the AUC 2, then it comes down to around 70 mg of carboplatin, 25 plus 12 into 2. So I think that's
excellent. Right. Ghanshyam, would you do the same thing or do you do something else?
Yeah. And actually, Dr. Samir, so I wrote that performance strategy is 1.
Yes.
So it's good. So the GFR, so the calculation, as how said, so 70 milligrams, so it's fair enough. So we can choose the either way of a weekly or a 3-weekly.
Excellent. Are there any other questions that I have missed out?
So I think we're done with our questions.
Okay, then I will hand over back to Senthil first to give the concluding remarks and take home messages. And if any of the faculty wants to add something, please raise your hand so that we can unmute you.
Let the faculty finish, sir. So I'll then wind up.
Okay.
Dr. Bowman wants to say something.
One point I wanted to make was that dose dense, in fact, the recent trial of ICON 8 has shown much more toxicity in a weekly schedule because the dose dense consists of carboplatinum of AUC 5 to 6 and weekly paclitaxel. So, in fact, the dose dense, what we say so-called, the Japanese one, it's not AUC 2 that we give. That is for frail patients. So, dose dense per se has more toxicity than 3 weekly. That's just a point I wanted to say.
Excellent.
Anybody else?
Yeah,
sure. Shall I wind up? Okay.
Please.
Thank you again, all faculty. It's been a great time. We've done 2 hours. So that really passed off fast, which tells us that the discussion probably has been quite interesting. So I think the most important carry home messages are that when you are practicing in COVID, you need to be careful, make sure that you're using your resources properly, make sure that you're taking care of your patients and your healthcare workers adequately, whatever needs to be done. Personalize your approach to your patient, because what's happening in Bombay may not be the same as what is to be happening in Hyderabad or Bangalore. It depends upon your resources, the number of cases, and how much your system is being taxed by the COVID cases that are coming up. So everybody does not need to do the same thing, both from a system standpoint and from a patient standpoint. It's very important to personalize at both levels. Coming to the academic point of it, everybody from the surgery group was in agreement that most patients would be sent for neoadjuvant chemotherapy. 3-weekly Paclitaxel is the standard. All of us agreed that you should test at least for germline. If it's possible, add somatic Brca testing. If it's possible, adding HRD would be even better. So if possible, do all these tests. Make sure you're counseling your patient adequately, both from a hereditary cancer standpoint and also from a therapy standpoint, wherein there's a lot of benefit with the addition of PARP inhibitors. So this is important to counsel your patient, try to do the test early so that you'll be able to take your patient forward as far as this therapy is concerned. Otherwise, I think personalization is the buzzword, and whether it's COVID or non-COVID, I think we need to personalize our therapy, and that's the way to go forward. Thank you so much, all of you, and let me hand it over back to the organizers, and thanks for the opportunity as always.
Thank you very much, Senthil. I just want to add two things which are not related to ovarian cancer, but tells us a lot about what is the COVID situation in India. As of yesterday, in the city of Delhi, there were 399 healthcare professionals who were COVID positive. 399 in Delhi. And in Mumbai, if some of you are familiar, there is a Goregaon Exhibition Center, which has 1.2 lakh square feet of exhibition area. That entire area is being converted into a COVID hospital. That is the quantum of preparation that the government is making, because the number is expected to increase. So I strongly feel that all of us have to make sure that we protect ourselves first in order to take care of our patients. And please remember that once this is over and done with, then if our family has to, weep on our dead body, then we can only blame ourselves. So please stay safe, stay protected, and make sure that you look after yourselves. With that, I thank everybody for a patient hearing, and 2 hours is a really long time. Thank you very much, and we would really appreciate free and frank anonymous feedback. There's a link that we have put up. We are not asking for your email address. Just give us the right feedback, constructive criticism, so that we can do a better job next time. Thank you very much, faculty. Thank you very much, panelists, speakers. You can sign off now. It's great that you were here for 2 hours to help all of us and the audience.